Okay, we're gonna get started. Hello, everybody. I know we have participants from many Europe and many parts of the world, Latin America, hopefully some from Asia. But welcome to the Frailty Seminar Series, our monthly webinar. Thank you all for joining. I know many more people are joining as we speak. And today we have a wonderful speaker too. I will introduce him in a minute. But before I do that, I'd like to go over a few things. One of them, remember that when asking questions, please use the Q&A button at the bottom of your Zoom panel. So you can ask questions. Try not to use the chat for that purpose. Remember that also at the end of the seminar, you'll be getting an evaluation link by email and reminders to complete it. This is very important for us. So we can improve the quality of the seminars. The other thing I want to remind you about joining the Global Frailty Network. It's a new organization of people interested in educational research aspects of frailty. We'll be sending more links on our new website. And I want to remind you, and again, I'll remind you later about our new next seminar in December by Dr. Linda Fried, who will be talking about frailty and aging. Before further ado, I think I cover all the things by now. I'll probably remind you at the end too again. Today I'm gonna introduce our speaker, Dr. Roger A. Fielding. He's an associate director of the Jane Mayer USDA Human Nutrition Research Center on Aging at Tufts University in Boston, and serves as leader and senior scientist of the Nutrition, Exercise Physiology, and Sarcopenia team. He's also professor of nutrition at the Friedman School of Nutrition Science and Policy, professor of medicine at Tufts University School of Medicine, and the associate director of the Boston Claude D. Pepper Older Americans Independent Center, a center of excellence in aging, longevity, geriatric research. Dr. Fielding is an internationally known researcher who studies the underlying mechanisms contributing to the age-associated decline in skeletal muscle mass. And he'll talk, of course, certainly a lot of frailty, where he does a lot of research too. The result of the impact on function of these muscle changes and the potential role of exercise, nutrition, physical activity, and other therapies on attenuating this process. He has published over 200 peer-reviewed papers with over 8,000 citations, has conducted numerous cross-sectional, longitudinal, and interventional studies examining the role of skeletal muscle power and physical performance in older adults. Dr. Fielding is associate editor of the Journals of Gerontology and Medical Sciences, Calcified Tissues International, and Musculoskeletal Research. He has also served as reviewer on numerous NIH study sections and was elected to the NIH CSR College of Reviewers. In 2015, he received the Olaf Journal Science Award from the International Osteoporosis Foundation. Today, Dr. Fielding will be talking about sarcopenia, frailty, and geroscience, certainly a topic of much interest to this audience. So welcome again, Dr. Fielding. Thank you, Roger, for joining us. And please start sharing your slide.
Thank you, Dr. Ruiz. And thank you, everybody. It looks like we have an international audience here, and it's great to be here. I'm just, share, here we go. It's great that Linda Fried is talking at your next seminar. I'll mention frailty a little bit, but I'm not going to talk a whole lot about frailty, but mostly focus on sarcopenia and some interesting new work that we have looking at some underlying mechanisms related to the geroscience hypothesis. So just a few disclosures. I think it's worth mentioning, but probably well known to this audience, that there is a huge demographic shift in the population of the United States that's occurring right now. And this is not unique to the United States, it's happening worldwide. We're seeing an explosion of the number of people over the age of 65 years. And I think the thing that is sort of not always as well recognized here is that the biggest increase in the over 65 population is the expansion of the number of people that are living to be over age 85 years. And again, accompanying this demographic shift, there will be inevitable increases in functional limitations, disability, and frailty in this in our aging society and population. Mobility, disability, this is an update from the census. These are data from the 2014 report. There are about 32 million people living in the community that have difficulty walking a quarter of a mile or 400 meters, including about 18.3 million who could not perform this activity. We see about 29 million adults that report difficulty climbing a flight of stairs. And again, about 3.9% were unable to perform this activity. And of course, this is higher in among older adults. So among individuals aged 65 and older living in the community, 39% had difficulty walking or climbing stairs, of which 10 million were unable to do either of these activities at all. I think it's really interesting and kind of cool that mobility is highly conserved across many species, and it's the same contractile proteins, except varied by a few splice variants that are responsible for movement, whether you're an insect, a bird, a fish, a dog, or a human. And it's these motor proteins that are highly conserved and really responsible for mobility. And it's also interesting that across multiple species, age-related motor performance declines. You can see this in the Drosophila here, which has a median lifespan of about 49 days. You can see that its ability to fly decreases significantly as the Drosophila age. And you can also look in rats and other rodents like mice and look at the relationship between motor performance tasks. There are many of these that can be performed in small animals, and their survival time. This is data from Christy Carter, looking at quartiles of performance score and its relationship to survival time or survival probability here relative to comparing high and low performers on these performance tasks. And not surprising, when you look at humans, something as simple as measuring habitual walking speed is also linked to survival or mortality. This is a large meta-analysis that was done by Stephanie Studensky in men and women, looking at the relationship between median survival and habitual gait speed or habitual walking speed. And this survival benefit persists even when you examine people into their later years of life. And while in our audience, we probably think about mobility issues a lot, sometimes I think mobility issues fly a little bit under the radar screen. I found it very, very interesting to notice that leading up to Queen Elizabeth's death, some of the news reports were not focused so much on any specific health condition that she had, but the press releases and pronouncements from Buckingham Palace were really related to difficulties with continuing mobility issues. Sadly, this was very shortly before her death, but the mobility, I think, is something that we don't always think about as being sort of a predisposing condition for other bad outcomes, but certainly is something that we need to really keep on the front and center radar. We believe that skeletal muscle plays a central role in the age-related declines in mobility. We now define this change in muscle mass and function as being sarcopenia. And I think we all agree that now this is really a syndrome that's characterized by progressive generalized loss of skeletal muscle mass and strength, with the risk of adverse outcomes such as physical disability, poor quality of life, and death. I think there's pretty much universal agreement that the components of sarcopenia really need to include changes in muscle mass, changes in muscle strength, and declines in physical performance. In the recent past, there is now even an independent, unique ICD-10 registration code for sarcopenia. It's not utilized very much, but it is on the books presently. I think that's necessary, but it's not certainly sufficient. And I think in the world now, there's been some novel approaches to ascribing a cut point or objective definition to sarcopenia. Some recent work from the European Working Group on Sarcopenia. They published a paper a couple of years ago, and the Sarcopenia Definitions and Outcomes Consortium, which was sort of an offspring of the original FNIH initiative on defining sarcopenia. When we think about these components that we think about as sarcopenia, there are ways to measure these. Just briefly, DEXA's dual energy X-ray absorptiometry. It has a very high precision, involves a very small radiation dose. For clinical and observational studies, these machines are widely available across clinical sites, so they have some utility in that regard. Although recently the data on DEXA as a predictor of a lean mass from DEXA as a predictor of adverse clinical outcomes, falls, fractures, mortality, mobility limitations has not been so robust. So I think this may be a technique that we have used but may not use going forward. Certainly computer imaging using computed tomography or MRI are measuring direct physical properties of muscle in various regions of the body. They have very high precision. CT and MRI have the added advantage of looking at the optical densities of the muscle cross-sectional areas, which are correlated with intramyocellular lipid accumulation. CT has a more substantial radiation dose, single slice CT. MRI obviously doesn't involve any radiation, although the costs in some cases can be more prohibitive. And there are some there's some participant burden associated with MRI. They have to lie still in the magnet for a period of time, depending on the resolution of the magnet. But these do measure physical properties of muscle and could be used both in observational and have been used in observational and clinical trials. And there are also new techniques that are being developed. This is just some really exciting data from Peggy Cawthon and Bill Evans looking at the D3 creatine dilution to measure whole body muscle mass. This is a technique that relies on the isotopic dilution of the total body creatine pool, which resides principally, almost exclusively intracellularly in skeletal muscle, showing that total D3 creatine as a measure of muscle mass is a very strong predictor of mobility limitations, difficulty bathing, other ADL activities, and difficulty walking. There's new data showing that it's also predictive of mortality, and some emerging clinical trial data showing that it's responsive to pharmacologic and other therapeutic interventions that target skeletal muscle. So new techniques are always being developed, and I think this one is going to really be important going forward. We also think about many different ways to measure muscle performance, including maximal strength using hand grip dynamometry or weight systems or isokinetic dynamometers measuring maximal force capacity or strength, looking at muscle power, which has a velocity component to it as well, muscle fatigue or the inability to maintain a given force output, and then also endurance capacity of muscle related more to the submaximal aerobic exercise time to exhaustion. The muscle performance issue, I think, is important because I think what you measure really matters. And when we're trying to think about how therapies and interventions really are targeting sarcopenia and are targeting muscle, depending on which of these measures you select, may impact the magnitude of the response and also be really relevant in terms of the mechanism of action of your therapy or compound of interest. We also need to target measures of physical functioning in clinical trials of sarcopenia. I think it's really important to measure robust, reliable indicators of physical functioning. And I kind of view physical function as a biomarker or a window that allows us to look into an individual's state of disability or role participation in their own environment. There are many of these that are available, both performance-based measures and self-reported instruments. Many of them, they are highly precise, including the 400-meter walk, 6-minute walk test, short physical performance battery, the stair climbing task. And in many cases, these have minimally clinically important differences that have already been derived for the populations that we're interested in applying them for. Now, there has been progress on defining sarcopenia. There are current consensus definitions have been largely based on expert opinion. All have included objective measures of muscle or lean mass. All have incorporated muscle weakness or reduced physical functioning into the definition. But until recently, sarcopenia criteria and cut points have not been evaluated objectively with respect to clinically meaningful distal outcomes like falls, fractures, mortality. And I think this is something that's hampered clinical trials and the field in general about how we really define sarcopenia. And I just want to acknowledge and highlight the work that Peggy Cawthon and Shally Basine did in sort of leading this Sarcopenia Definitions and Outcomes Consortium. What they did in this large single subject pooled meta-analysis, over 20,000 older men and women that were in many of the large epidemiological cohort trials, was that they used regression tree analysis to develop appropriate cut points using muscle weakness, grip strength, and walking speed. And then they looked at how muscle weakness and walking speed predicted distal clinical outcomes, and looked at them in isolation and then also in combined. And you can see that in most cases, when you combine slow gait speed with weakness, there's an increased hazard ratio for falls, mobility limitations, mortality, and hip fractures. This was in women, and the data are very similar in men. So this is the first, I think, these are the first applicable, objectively derived cut points for muscle weakness and slow walking speed that I think could be very useful in coming up with an objective definition of sarcopenia, and one that we can use to enroll and identify patients for clinical trials and move towards coming up with a consensus definition, not only in the US, but across the world, about what really this syndrome is and how we effectively measure it. Now, I wasn't going to talk much about frailty, but I think it's important to understand the frailty phenotype in the context of sarcopenia. These are the 5 criteria that were derived and validated by Linda Fried and her group when she was at Johns Hopkins. They include weight loss, weakness, exhaustion, slow walking speed, and low activity. And I think without thinking too much about this, you can see that many of these are related to skeletal muscle dysfunction and skeletal muscle loss. And one of my European colleagues has always sort of said to me that sarcopenia may be the underlying substrate for physical frailty. So frailty and sarcopenia are not the same thing, but I think there is a clear relationship between this frailty phenotype and sarcopenia. And I also think when we're thinking about intervention studies in clinical trials, it may be really hard to go after reducing frailty or preventing or reversing frailty, but we may be able to target interventions, develop interventions that target the components of the frailty syndrome, and maybe enroll patients who have frailty or pre-frailty and see if we can target the components of frailty. There have been a number of interventions that have been studied with respect to sarcopenia. These include pharmacologic interventions and lifestyle interventions. Pharmacologic interventions have really been compounds and biologics that have targeted skeletal muscle growth. There's some novel compounds that have been developed to target neuromuscular transmission and contractile properties, targets related to energy transduction and mitochondrial homeostasis, and also some studies that have looked at therapies and medicines that are currently approved for other indications, but that may be appropriate for sarcopenia. And there have been a number of well-described physical activity and nutritional interventions that have also been evaluated with respect to how they may impact sarcopenia or some of the components of sarcopenia. And I think in this era, we also have to start thinking about combined therapies, depending on the severity of symptoms, depending on the target population. We may also want to know really how some of these pharmacologic interventions may work in the context or in combination with some of the well-validated lifestyle or nutritional interventions. In terms of the pharmacologic therapies, the major categories, there's been a lot of work done in the selective androgen receptor modulator space. These are the SARMs. These are both steroidal and non-steroidal molecules. There has also been work done looking at the myostatin signaling pathway, both with development of humanized monoclonal antibodies and receptor ligand trap antibodies. As I mentioned previously, modulators of neuromuscular function, including compounds that sensitize skeletal muscle troponin and activate skeletal muscle troponin, compounds that affect mitochondrial biogenesis, I'm thinking primarily of the sirtuin activators and regulators of mitophagy. And then there are some medicines and dietary supplements that have been approved or marketed for other indications like aspirin, vitamin D, omega-3 fatty acids, and some of the ACE modulators. So I'll discuss some of these in a little bit more detail as we go through. The SARMs are ligands that bind the androgen receptor and induce tissue-specific activation of AR-dependent genes. Generally, they're dual anabolics because they have effects on muscle and bone, and almost universally do have effects on adiposity as well. So there's this synergistic effect, if you will, on muscle, bone, and reducing fatness. There are AR agonists and antagonists, and the major classes are steroidal and non-steroidal. The advantages of the non-steroidal SARMs are that they have more tissue selectivity and have less of the off-target effects. But, you know, the story with SARMs really started with one of the first randomized controlled trials of fairly high doses of testosterone enanthate that was done by Shelley Basine now several years ago. It had been known that anabolic steroids had been abused by athletes for many, many years, yet there had never been a randomized controlled trial done looking at the effects of anabolics on muscle strength and muscle mass in healthy male volunteers. And this is the study that Shelley actually did back in the 90s, looking at the effects of testosterone versus placebo in men that got testosterone alone or testosterone with a resistance exercise training program. And you can see that when you give 600 milligrams of testosterone weekly to these young, healthy men, you get a very robust increase in fat-free mass, muscle size, bench press, and squat muscle strength. And it looks, in fact, like that effect is actually enhanced when you add resistance exercise training to the pro-anabolic therapy here. What's important, I think, here is that these studies on high-dose testosterone resulted in really robust increases in fat-free mass and muscle mass. And I think the reason that other compounds in this SARM space have gone after muscle mass as a target is because of the effects that we saw in these very early studies of testosterone. You can also see this in older men. These are lower doses, up to 300 milligrams a week of testosterone here, looking at the changes in muscle mass, leg press strength, leg press power, and leg press fatigability, showing that the most robust effects are at the high doses. This is data from Tom Storer and Shelley's group. And then, unfortunately, when lower doses of androgel were applied in a large randomized phase 3 trial of testosterone in older men that were hypogonadal and that had some mobility deficits, there was not a meaningful or clinically meaningful increase in 6-minute walk distance in the individuals that got androgel compared to placebo over 12 months. And in this study, a clinically meaningful improvement was greater than 50 meters over six minutes. That may have been too high. That may explain why there was no effect of testosterone, but it also may be that the dose that they used was relatively low, and these men had low circulating testosterone concentrations to be enrolled in the study. So we were bringing people from subphysiologic levels. They were bringing people from subphysiologic levels up to more physiological levels of testosterone. The trials that had been done with the non-steroidal SARMs, the newer SARM compounds, this is a compound called enobosarm that was developed by GTX in patients with cancer cachexia with greater than 2% weight loss. This was a small study done in cancer patients with weight loss in 6 months with 2 doses of enobosarm that showed a statistically significant increase in lean body mass that was about 1.5 to 1.3 kilograms, and a corresponding increase in stair climb power in this small phase 2 trial of lung cancer patients. However, when they went on to do their phase 3 trial specifically in non-small cell lung cancer, they had a co-primary endpoint of change in appendicular lean mass and stair climb performance power. They did not meet the co-primary endpoint, despite the fact that there was a consistent increase in lean mass. And in those individuals that had greater than a 0.25 kilogram increase in lean mass, there was an improvement in stair power. However, the phase 3 trial was not successful. Myostatin has been another area in sarcopenia that's been of great interest. The GDF8 protein is a negative regulator of muscle mass by activating the activin 2B receptor and activating SMAD signaling in skeletal muscle. This turns on a number of transcriptional regulators of the atrophy genes in skeletal muscle. And you probably know that the deletion of the myostatin gene in mice, the myostatin knockout results in this really easy to see hypermuscularity in the mouse model. There have been a number of clinical trials with monoclonal antibodies against myostatin. This is a compound that was developed by Regeneron in a study that I led looking at Regeneron, this myostatin monoclonal antibody in combination with a low intensity resistance exercise training program. And you can see very nicely with 4 subcutaneous doses of the myostatin antibody over 12 weeks. This is the change in MRI measured thigh muscle volume. It increases significantly, about a 3 to 4% increase in thigh muscle volume over 12 weeks in the groups that got the monoclonal antibody plus with or without resistance training compared to placebo here, and less easy to see, but more variability. But in general, the individuals that got the antibody plus resistance training did have a significant increase in chest press strength, but no real change in leg press strength. There are no differences between these groups. There's well-known activin 2 antibody, bimagrumab, that's been developed by the Novartis company. This is looking at bimagrumab in older men and women over 24 weeks. Again, this is infused. You can see there's a significant change in thigh muscle volume here of about 9% by 8 weeks that persists here. There's a significant increase in lean body mass of about 2 kilograms. And this resulted in also a corresponding increase in hand grip strength with this activin 2 antibody. Remember, myostatin is a negative regulator of skeletal muscle growth. So when you block the myostatin or block its signaling, it results in an increase in muscle mass, and at least in this case, an increase in muscle strength. Interestingly enough, there was not overall a significant difference between bimagrumab administration versus placebo on change in the 6-minute walk distance. However, when you looked at individuals at baseline that had a slow or a short 6-minute walk distance, those individuals had a robust response to bimagrumab compared to placebo. So individuals that were slow walkers at baseline seemed to be more responsive to the antibody administration than those that had a higher baseline walking ability. However, when they repeated this trial, recruited only slow walkers in the trial, there was no effect of bimagrumab. And in addition, they did another phase 2 study in patients that have chronic obstructive pulmonary disease. And again, they saw that in the COPD study, there was this same increase in thigh muscle volume with bimagrumab, yet there was no significant change in 6-minute walk distance in that study. So, you know, the pharmacology space here in sarcopenia is littered with failed trials. So some of us have started to think about why some of these trials really have failed. And I think it's because of a number of issues. The SARMs and some of the myostatin antagonists are in fact weak androgens. And in some cases, I think the dosing that they've used has been low. In some cases, there have been some trial design issues, too many groups, too many comparison groups, relatively small samples, poor execution in some cases. maybe not engaging the correct target population and not really thinking carefully enough about the indication. Some of the larger trials have not really included an exercise or behavioral intervention. And, you know, I think in this space, there have been a number of regulatory issues. The bar for sarcopenia is very high. We still struggle with this lack of a consensus definition and link for some of these definitions to hard clinical endpoints. The endpoint selection and the primary outcomes that have been selected in these trials have varied. There has been failure to demonstrate in a meaningful way how the patient lives, feels, or functions. And I think there's been a lot of pressure from the regulators that we need to sort of use patient-reported outcomes in these trials, at least as secondary outcomes, if not maybe primary outcomes. And there's been lack of progress in the development of useful and appropriate patient-reported outcomes for individuals with sarcopenia. Despite that, there have been a number of other novel therapies that have been in development, and I think these have moved away from targeting specifically skeletal muscle mass to other components of muscle function and muscle performance. And I think that's important because we know with aging that muscle mass declines at about 0.5% per year, but if we look at muscle strength or muscle performance, it declines at about 1% a year. So there's got to be other factors beyond mass that contribute to these declines in muscle performance that we observe. Some of those involve sensitizing the excitation contraction coupling system. This is a compound that selectively sensitizes skeletal muscle troponin to ionic calcium so that it results in an increase in skeletal muscle force production at a given level of neuromuscular stimulation. So really doesn't rely on increasing muscle mass by hypertrophy, but actually increasing muscle force output by enhanced EC coupling. There have been a number of targets of mitochondrial function that have been developed. This is the allegetanin naturally derived urolithin A, which in preclinical models has been shown to increase grip strength and running distance in older mice. And also the compound nicotinamide riboside, one of the niacin-like compounds, had similar effects by different mechanisms, by increasing mitochondria, looking at improved running distance and grip strength. There have been some positive findings with urolithin A in human studies, both looking at its upregulation of mitochondrial genes from skeletal muscle biopsies in humans, and also looking at improvements in muscle fatigue with urolithin A administration compared to placebo. So I think we'll see some more exciting work in this space as well. There have been also compounds that have been looking at activation or inhibition of the angiotensin converting enzyme pathway that has deleterious effects on skeletal muscle through angiotensin II receptors, but also activation of the angiotensin converting enzyme pathway by activating angiotensin 1 to 7 and activating the MAS receptor, which may be responsible for inducing muscle stem cell proliferation and increasing myogenic differentiation. So there's a number of compounds that are looking at ACE inhibition and ACE activation as potential therapeutic strategies for skeletal muscle. We also know that inflammation is an important part of aging and age-related changes in muscle strength and function, and those individuals that have high basal inflammatory burden may have accelerated loss in strength and walking speed, and targeting inflammation, although it hasn't been successful to date, may be another important mechanism by which we can affect muscle with aging and really treat and attenuate changes in sarcopenia. Let me skip over a couple of these because I think we're getting on time here. You know, it's still really clear that exercise still to date is the only treatment for improving physical function and preventing disability in older adults and really attenuating some of the components of sarcopenia. We know that resistance training exercise has profound effects on muscle mass and muscle strength, particularly in healthy older adults. This was a study that was done at Tufts in older women, a 1-year progressive resistance training intervention compared to health education control. These women trained twice per week. These were all healthy postmenopausal women. And you can see the robust increases in total body lean mass here with resistance exercise training compared to the health education control group. And I would argue that this was similar to what you see with a non-steroidal SARM that we saw with enobosarm, for example. So this is a very pro-anabolic training intervention in older adults, and it's still something that can be beneficial. And we know also from the larger randomized trials that exercise can improve physical functioning and reduce disability. This is the largest randomized trial that was conducted of exercise in older adults, the LIFE study. The main trial, the phase 3 trial, involved 1,600 older men and women with an average follow-up of about 2.7 years. This study compared a multimodal, group-based aerobic and resistance exercise training intervention compared to a health education control group. And the primary findings of physical function improved in the group that got the physical activity intervention, but it also resulted in about an 18% reduction in mobility disability. In the LIFE trial, the onset of mobility disability was defined as the inability to walk 400 meters. So at baseline, you can see here at time 0, all of these participants could walk 400 meters, and then they were followed every 6 months until they failed to be able to complete the 400-meter walk test. And you can see that there were more failures in the group that were randomized to the health education group in yellow here compared to the individuals who were randomized to the physical activity group. And the overall risk reduction was about 18%, which was statistically significant. So significant reduction in acute onset of major mobility disability. Now, I hinted to the idea that there may be a biological basis for some of these changes in physical functioning and muscle function with advancing age. Just the fact that this happens across multiple animal species is really suggestive, I think, that there may be a biological basis. And we're learning now that there are about many more of the hallmarks of biological aging. One of those is cellular senescence. We know that now that cellular senescence is a hallmark of aging. Senescence really refers to that cells in most tissues become senescent with advancing age in response to diverse forms of either genotoxic, proteotoxic, metabolic, or inflammatory stressors. This results in changes in the morphology and upregulation of many cell cycle regulators, anti-apoptosis pathways, and also a very robust senescence-associated secretory phenotype. So these senescent cells, when they develop, actually start secreting and pumping out a whole set of these SASP molecules. Many of them are proteins, cytokines, chemokines, matrix remodeling proteins, growth factors, and other molecules. So it's not only the cells that become senescent that really get disrupted, it's the inflammation, deterioration, remodeling, and compromise of regenerative capacity that this senescence-associated secretory phenotype induces that is really the bad player in cellular senescence with advancing age. So we had an opportunity, and there's evidence for the SASP. Preclinical models really using senescent cell transplantation show that the SASP will compromise muscle performance and physical functioning. If you pharmacologically suppress the SASP response, it's been shown to improve physical functioning and muscle performance. And senescence biomarkers have been developed and have been associated with chronologic age and clinical manifestations of advanced biological age. For example, disease burden and advanced adverse outcomes following surgery. This is very nice data from Marissa Schaefer and my colleague Nathan Labrasser at the Mayo Clinic, looking at a number of these senescence-associated proteins, or SASP proteins, and clinical outcomes. This is data on patients with aortic stenosis and who gets rehospitalized with aortic stenosis. And you can see that many of the SASP factors are higher in individuals that have rehospitalization: IL-6, VAHS, TNFR1, GDF15. So these are associated with rehospitalization in aortic stenosis. And then if you look at the area under the curve of sensitivity and specificity of this 7 SASP panel to predict rehospitalization, you can see that it's almost 0.9 here compared to just looking at the regular sort of frailty comorbid frailty index here, or other sort of biomarkers or predictors of rehospitalization here. So this seems to be a very strong marker of these clinical outcomes. The SASP proteins are a strong marker of these clinical proteins. So we looked at 27 validated senescence-associated phenotype protein markers in the LIFE study. So we had biomarkers measured at 6, 12, and 24 months. This was in 1,300 participants of the LIFE study. And at baseline, we just wanted to ask questions about how these were related to physical functioning and physical performance. So these are all the biomarkers. We use Luminex multiplex assays to measure all of these except activin A, which was measured using an ELISA. These are the subjects that we were able to measure the biomarkers on. I just want to call attention to the fact that the average age was about 79 years, body mass index of 30, so they were all overweight or obese. They had an average short physical performance battery score of about 7, so they were not physically robust. Average gait speed was between 0.7 and 0.8 meters per second, and relatively low grip strength here. So this was a fairly compromised population. When we looked at our senescence phenotype proteins related to age and sex, activin A, GDF15, and the RAGE proteins, and 10 other biomarkers demonstrated significant positive associations with chronological age. In other words, higher biomarkers levels, higher SASP burden at higher ages. There were also some sex differences here, with some of these being higher in females and some of these being higher in males. Not going to try to decode the sex differences for you here today, but we did note some. And interestingly, when we looked at this panel of SASP proteins and our measures of physical functioning, in this case, we looked at the short physical performance battery score, the SPPB here, and its components: 4-meter gait speed, chair rise, and balance. This is the overall relationships. These are the univariate relationships between SPPB and the individual biomarkers here on this heat map, and then the components. You can see that overall there were some strong and significant associations between the total SPPB score and the biomarker concentrations. In other words, higher biomarker concentrations generally meant poorer or lower performance on the SPPB score. And those that were correlated most strongly were activin A, which you can see here, VEGF-A, and MMP7. When we looked at the components, we saw similar associations with many of the components of the SPPB also having strong associations with activin A, VEGF-A, and MMP7. Interestingly enough, ICAM1, which is a adhesion molecule, seemed to be counterintuitive. In other words, higher levels of ICAM1 were associated with better SPPB performance and better performance on the component SPPB scores here. We also saw similar relationships, although less strong, with the performance on the 400-meter walk test. We did some gradient boost modeling of these to look at the variable importance of these components, to see which of these really contributed more strongly to the regression models. And again, Many of these were similar for the SPPB, Activin A, ICAM-1, MMP7, and for the components of the SPPB score. Because we knew that low SPPB score, low SPPB score below 7 was really, well, those are individuals that are at the greatest risk for mobility disability. We also looked at the top 10 biomarkers that predicted low SPPB score and looked at the receiver operator characteristics. These are the three models. Model 1 here in dark blue is the top 10 biomarkers plus age, sex, race, and BMI. Model 2 is just the top 10 biomarkers alone. And model 3 is just looking at age, sex, race, and body mass index alone. You can see that the ROC for the known covariates here is actually pretty poor. We have an ROC of about 0.68. Yet when we look at the top 10 biomarkers with or without the covariates here, they actually are pretty strong predictors of poor SPP performance. The model in the model in the training set, this is about 1,000 individuals from the life study, was about 0.93. The model in the test set drops a little bit. This was about 300 individuals down to about 0.86, but pretty strong association, predictive value of the top 10 senescence-associated protein biomarkers with low SPPB performance. We also looked at low gait speed as a predictor here, gait speed less than or equals 0 to 0.8 meters per second. This was not as strong as the composite SPPB score, and maybe that's because it's probably better to use a composite score as a predictor when we're using these biomarkers to predict here. Again, there was an association, but was not as strong as with the SPPB. We did look at the biomarkers for grip strength. There were some similar biomarkers that were predictive of poor grip strength, including Activin A and GDF-15. But when we looked at the GBM boosting modeling here, we got some other biomarkers that seem to be in the top 10 of variable importance here. And that may be because age is such a strong predictor in the GBM modeling here for grip strength, that it maybe we lose some of these individual univariate effects of the association with grip strength. We did look at RC analysis for weakness using the SDOC criteria for low grip strength here of below 20 for females and below 35 for males. The biomarkers didn't do such as good a job at predicting poor grip strength as they did for the SPPB here, but we did do this analysis. So I'd like to close there. I'm sorry I went a little over time, but as you can see, skeletal muscle function really encompasses a very complex dynamic system. I would say that multiple targets for therapies and indications in sarcopenia remain or underexplored. SARMs and myostatin antagonists have had limited success in improving physical function in trials of sarcopenia. I think we still need to move towards developing a universally agreed upon definition of sarcopenia, and that will clear some of the regulatory path as we go forward and also help us identify the appropriate target population. I think future trials in this area should be adequately powered to explore multimodal interventions so that we can understand the interactive effects of even permissive levels of exercise or physical activity or rehabilitation in combination with pharmacological interventions. I think the continued need to organize clinical trial networks should facilitate our ability to do clinical trials in this space, like the Life Study Group in the United States. Also, the recently completed SPRINT-T consortium in Europe may help to refine and standardize outcomes and really define appropriate enrollment criteria. I think we need more development of patient-reported outcomes. We need to develop appropriate outcomes that can demonstrate how a patient lives, feels, or functions in sarcopenia trials. And obviously, we need to do a better job of increasing awareness of sarcopenia among clinicians and the public. And now I think we're also understanding that in this space of sarcopenia and physical function and muscle performance, that there may be some biological basis for this, and there may be some associations with some of the hallmarks of biological aging, in particular, some of the ones I shared with you on cellular senescence. So thank you, Dr. Ruiz, for giving me this opportunity, and thank you for your attention this afternoon.
Thank you, Roger. Thank you. Please stop sharing your presentation so I can, thank you. And now it's time for questions. We have a few questions there in the audience. And before I do that, I don't want to forget to tell you that, of course, the next webinar in December is Dr. Linda Fried, Frailty and Aging. And this is very important too.
Yeah, my last slide was that, and I forgot to show it. So please, yes.
Yeah, and Dr. Fielding, of course, is one of the organizers of the International Conference on Sarcopenia, Frailty and Sarcopenia Research in 2023. And of course, the deadline for abstracts and symposiums and oral communications is coming up, December 6, 2022. This is the leading conference in frailty and sarcopenia research. And of course, you have the benefits of attending Toulouse, France. So I just wanted to say that. And now, of course, we're going to ask questions.
Yeah, and I look forward to welcoming all of my colleagues here on the Zoom to our meeting in Toulouse next year. And as you know, we had to do some virtual meetings because of the pandemic, and we had a hybrid meeting last April that I think was successful, but we're really looking forward to having a robust in-person meeting next March. So thank you, Dr. Ruiz, for bringing that up.
No, thank you, Roger. So we have a few questions. One for Dr. Saori Harada. She agrees with I guess the diagnostic accuracy of CT MRI, but she's also asking about the role of bioelectrical impedance analysis that is more available and easily to do. So any comments about that, Roger?
Yeah, I mean, I think it's really important that we do have easy to perform tests to assess muscle mass and muscle quality. I would say that at the individual level, I think the variability in BIA is somewhat limited to really understand what someone's muscle mass is. I think for epidemiological, for population-based studies, it might be appropriate, but at the individual level or to look at change in clinical trials, I still think it has a lot of limitations. So I would be reluctant to recommend that. But I do understand there is a great need to have, more portable, user-friendly, lower cost tools.
Right. The other question is actually a question that we're thinking about asking, and it's from Amani Ali, is what about frailty, I guess, measured for participants in these studies? I will add to it frailty as a risk factor or frailty as an outcome. And I saw that you have some of that in the life SAPS study, right?
Yeah, that's a good question. Some of the early SARM trials, the myostatin trials, didn't target frail individuals specifically. They may have the participants may have some components of frailty. I don't know if that was always assessed, and many of them may be pre-frail. And I don't know if people have done any secondary analysis on response in pre-frail or frail individuals. We did, and I was going to show these slides, but I would have too much. We did a secondary analysis in the life study looking at the effects of the physical activity intervention on components of frailty, and also looked at how frail individuals at baseline responded to the intervention. There's some confounding there because if you use the free definition, low physical activity is one of the components. So if you give people physical activity, that you improve their frailty status, right? So it's not, so we use the soft definition. What I can say is some components of the frailty did improve with physical activity using the soft criteria. And also in individuals who were frail at baseline, their prevention of mobility disability in the physical activity group was similar to the overall effect. So individuals that started out frail did have a reduction in onset of mobility disability with the intervention. We haven't looked at any of the biomarkers yet by frailty status, but that's certainly something we plan to do in our senescence project. Great.
Another question, I guess, is more general, but it's about the role of nutritional therapy and specifically omega-3 proteins, because I think there has been few studies coming up on the role of omega-3 in sarcopenia and frailty.
Yeah, there was a study, I was going to show it again, but a study in relatively healthy older adults showing if you give 3 grams of omega-3 fish oils per day, I think it was for 12 weeks or 6 months, there is improvements in strength and mass and seem to be promising. We participated in the Energize consortium where we gave it was a 2x2 factorial design looking at omega-3s with and without angiotensin receptor blockade of losartan in older adults that had slow walking speed and had elevated baseline inflammation. And when we gave 3 grams of fish oil to those individuals, there was no change in IL-6 levels over a year, so no change in inflammatory burden, and there was no improvement in walking speed. So we couldn't show it, at least in those individuals. Now, maybe the dose wasn't high enough. Maybe, again, with omega-3s, maybe there's a need to have some interactive effect with physical activity intervention. That's something we might like to pursue in the future. But we haven't had a real good, we didn't see a really good response with omega-3s.
Okay, another question about the use of estrogen, testosterone on postmenopausal women and sarcopenia and or frailty.
There have been some studies looking at low dose testosterone in older women, and also, and there's some studies that are ongoing. I don't know that, obviously, that's one of the reasons that the non-steroidal SARMs that have been developed, they're more targeted and they can be used in both men and women. So I don't have much more to say about estrogen or testosterone in women than that.
Another question about, I guess, Prolia, the denosumab that is used for osteoporosis, but also some people have started using it for sarcopenia. Any studies that suggest that it may be a promising strategy?
I mean, I think it would really help to do the clinical trials to understand that. And, bone anabolics may have effects on muscle. And I think that's, there's a lot of overlapping mechanisms by which bone loss is accelerated that are common to acceleration of muscle mass. So that's certainly possible. But I think the clinical trials need to be done.
Another one is about, as the physical function is already considered a biomarker of disability, what is the place of the, I guess, SAS proteins, since it looks as they are strong biomarkers of muscle function?
Well, I mean, I think one thing is this could be you could think about developing a blood test or a panel of biomarkers that could assess someone's functioning without having to measure their gait speed, measure their walking speed. So to do things remotely might be easier to just get a blood sample or a blood spot. And 2, it may also help us identify specific pathways that we could target for intervention. For example, it's really interesting. I was really surprised that one of the strongest hits we got with of the biomarkers, for the SAS biomarkers, is activin A, which is part of the very closely related to myostatin. So this is activin A is another negative regulator of muscle growth. So there may be some pathways that could be targeted that might be prime for intervention by studying these SAS proteins. And then they can also be used as markers for intervention if we can look at response to therapies. We're going to look at the changes in the life study. We haven't done that yet, but they may be biomarkers of response as well.
Right. Another question, I guess, related to the original question on bioimpedance and practical methods to measure muscle mass is the role of ultrasound, because I think we're seeing more studies on that.
Yeah. I think there are people that are interested in using ultrasound. I think that there's been efforts to standardize placement and approach, and I think those still need to be refined to be really sensitive and responsive to change. And I think where you put the probe and how you place the probe on the person's body is really important. And to make that a quantitative assessment, I think there's a lot more work that does still need to be done.
I guess we have another question before we wrap up. That is the relationship between insulin resistance, frailty, I guess sarcopenia 2, and positive outcomes. I guess the question refers also to resistance training, I guess interaction with insulin resistance.
Yeah, I mean, certainly insulin, as you know, is not only important for stimulating glucose uptake into muscle, it's also important for stimulating amino acid transport into muscle. So I think that there's probably some overlap between this concept of insulin resistance, which is related to worsening of glycemic symptoms, but also anabolic resistance, which is really an inability of the muscle with aging to take up amino acids and induce protein synthesis. So they are overlapping. And, you know, we do know that exercise and even resistance training exercise does have a positive and insulin sensitizing effect. And it may also overcome some of the anabolic resistance we see with aging as well.
Great. Thank you. It's 1 p.m. now, and I think we're gonna wrap up the presentation. And again, many thanks for an excellent presentation, Roger, for Dr. Roger Fielding. Thank you again for the insightful questions. And again, I want to remind you of completing your evaluations and the upcoming Frailty Seminar Series in December with Dr. Fried. And don't forget again to submit your abstracts, symposiums, or presentations to ICFSR 2023 in Toulouse, France. And the deadline is December 6, 2022.
Perfect. We'll see you all in Toulouse. Thank you very much.
Well, take care, Roger. Thank you.
Bye-bye.